Welcome everybody to the Minnesota Elder Justice Center Thursday webinar. Watching our participant numbers build here, and happy to welcome folks this afternoon. I'll just wait a moment as folks are entering the Zoom space before I have the exciting opportunity to introduce Amy and talk a little bit more about the webinar. Those numbers are building quickly, so I think I'll just go ahead and get started. I'm just delighted that folks are here to join us this afternoon on the Minnesota Elder Justice Center webinar. I'm bearing greetings from Renee Strami, who is often here with you in the afternoons on Thursday afternoons. Renee is not available today, and I get to be here, which is a great pleasure because of the program that we have to present today. So, with no further ado, I would like to jump into our program slides. And now here I am already not as smooth as Renee. This is where I have to ask our kind audience to bear with me as I as I manage the Zoom. And I just want to welcome folks here. We're talking today about a community risk reduction strategy that Amy is going to present to us. That is in a very engaging service model that I am very excited to discuss with the webinar audience today. I want to welcome you again. This is a part of a Minnesota Elder Justice Center webinar series. And here's some information about our organization. I like to share this. Here's our mission, share our values as an anti-racist organization, and our work areas around public awareness, professional education, what we're doing here today, public policy advocacy, and direct service work. If you would like to access our direct services, we provide advocacy for folks who may have experienced abuse, neglect, or financial exploitation, or the people who care about those individuals. You can reach us at these contact points. Here's a telephone number, 651-440-9312, and you can reach us via our website here as well. You'll find a form there to reach out directly to our advocacy victim services team. As part of our work, we do offer these free webinar opportunities. We're very excited to be able to talk about innovative programs like the ones we're talking about today. You'll see the program coming up here. We've got webinars scheduled throughout September. Renee is really listening to what you've got to say when you're sharing evaluations and requesting information from us. And we're so happy to be able to offer these programs. Please feel free to join us at any of these upcoming webinars. Um, you'll see we have a couple of date breaks. Notice on September 28th, we will not present a webinar. The Age Friendly Minnesota Conference is taking place from September 27th to the 29th. There will be a lot of content during that Age Friendly conference that will be on point with issues that are of concern to you in your work. And so we want to direct folks' attention to that conference taking place on those dates. And then upcoming, we'll have a little break in October. For more information about our webinars, you can find out what's coming up on our website as well. We do offer CEUs. We're pre-approved to offer social work CEUs and for BELT's Board of Examiners for Long-Term Services and Supports. Folks with questions can always reach out to us about that. And then just some brief logistics for today's webinar. We'll be in webinar mode. That means that Amy and I have the ability to broadcast ourselves, but everybody else is automatically on mute. No videos here, so you are welcome to use the Q&A box or chat box to engage us and one another, and I'll break that down a little bit too. But I also just want to say that so you should feel free. This is what Renee prompts. Feel free to eat your lunch. Just enjoy your opportunity to have video off, audio off, and join us for some learning. And feel free to engage with us and with one another using these chat and Q&A box mechanisms. If you look at the bottom or top of your screen, depending on whether you're using the app, you'll see there's a chat icon, which is a word bubble. Chat is great. I'll share some information and announcements there. You can engage one another through the chat. Lots of times we'll be talking about something and somebody will have something Jermaine, they'd like to share. I love these webinars for the group of professionals that are gathering together in this space periodically, so we can use that to our advantage. And if there's information folks would like to share with one another in the chat, feel free to do so. For questions for Amy or I, or questions about the program we're addressing, if you can focus those in the Q&A box, please. That helps me as I am looking through the questions and trying to make sure that Amy hears the questions that you want to pose to her. So just feel free to use the Q&A box as you can for questions related to today's program. And then information sharing will happen. I'll try to keep that happening in the chat too. If you need closed captioning, you can see an icon on your screen that allows you to enable closed captioning. The icon is a CC button in some views, so you can click that and you'll have the option to enable that. We will send along a certificate of attendance. I'm going to say this now as our group is joining here. We will send it along. I will put it in the chat. We will send it along, and I will say it throughout. So do not worry. If you are in attendance here throughout the presentation, you will receive that form in your email. It may come tomorrow. It may not come today. So just wait a little while and see that that form comes. If you have not received it by early next week, then let me know. But wait just a little while. It's not an automatic process. We do have to do a few things on the back end here in order to provide that to you. So we will send it out. There will be a recording posted. That will take a moment too, and then we'll put that up and will be available on our website. And then at the end, you will experience our survey request for information. This is where we know that you want to hear about programs like the programs that Amy has developed. We want to continue to hear from you about the things you'd like to learn about. So please feel free to share those ideas with us on the survey. We do take those recommendations and comments very seriously and are grateful to you for taking your time to tell us about the things that are important to you. I'm thankful for that. So that will happen after you leave the Zoom program. If you enjoy and value these learning opportunities, we also welcome your support. We like to make these free, and we're glad to make these available to everyone through the recordings as well as the webinar itself. So please consider visiting our page here at givemn.org. And finally, I will stop talking about housekeeping matters and turn the Zoom screen over to Amy. Amy, welcome. Thank you so much for joining us. Here you'll see, and I know you have seen Amy's more detailed bio. Amy is the founder and CEO of Care Resource Connection, and Amy is also the Community Health Program Director for the City of St. Louis Park Fire Department. So I just am so grateful, Amy, that you are here to talk with us today. Thank you very much.
Thank you, Merritt. Welcome, everybody. I appreciate you taking the time to join us over your lunch. I know that you will be able to communicate via the chat there for your questions and answers. Chief Coring is on the group, so if there's additional questions that you have for the fire chief himself, know that he is there to type back for some specific questions, and we can always at the end, follow up individually as needed. I would love to say that I alone was able to come up with this community risk reduction strategy, but it truly is a team effort. As a founder of Care Resource Connection, we have 4 programs. So our first is Beyond the Lift. We have our program called Journey Home. We have Beyond the Fire, and then we have our Community Health Alliance, which is kind of imposing, takes all of them together, right? So we're unable to do what we need to do without our partners with the fire department. So Chief Coring and I came together and we founded the Community Health Alliance, which is what brings all of our programs to the forefront, with having the fire department leading these efforts. And you see the fire department and not necessarily see Care Resource. We're more behind the scenes, and that's where we should be. So what we do is we come into the communities, we sit down with the fire departments, look and see where their pain points are, review their data of their 911 calls, And Chief Coring has conversations with the fire chief to see if this is something that they not only want, but are they ready for? There is some things that we have to look at to prepare and get ready for this. Next slide, please. And so our vision at the St. Louis Park Community Health Alliance vision is to connect residents with the right resource, the right services at the right time. The work of the Alliance better utilizes the community resources to provide superior health outcomes for residents, their families, and the providers supporting the community. So it's really a community-driven program. Yes, we start with the fire department and we work in that way, but we also look and see not only is it other nonprofits, other resources in the community, but we also engage the health system and everything that's kind of coming into how we're able to build this alliance. And it organically builds itself. And so that's the beauty of it. Next slide, please. So the history again. So, you know, before Care Resource Connection, we did have quite a few repeat calls. We focus on the seniors, right? So we focus on lift assist, we focus on falls, because I want you guys to think about when somebody calls 911 and the fire department responds, it is the fire department's job to come in as a first responder, to come in, assess and respond, and then they typically take it and send it over to a higher level of care like the paramedic, and then they go to the hospital. But many seniors, as we know, decline. They decline to go to the hospital, and for many different reasons. And so that's where the Beyond the Lift program comes into play. It's near and dear to my heart. My grandfather passed away because of a fall, and repeat falls actually. And so it was one of those things that I think we need to be able to look at how we interject when it comes to the lift assist calls. So again, before Care Resource Connection, there really wasn't a program that existed for this. And so now after we did the Beyond the Lift program and utilizing our care coordination model with the fire department, the St. Louis Fire Department has seen a dramatic decrease in repeat calls because we follow the resident that's calling for help for 120 days. Next slide, please.
Amy, I'm gonna advance to the next slide, but I'm also gonna see if I can adjust. I'm gonna stop sharing for a second and see if I can adjust the screen share so folks can maybe get a better full screen view. Just let me try this, everybody, because I hear in the chat some folks are not able to see the full screen view. Let me try this. Okay.
There you go.
We'll try this and see if this works a little bit better for folks.
Perfect. So the big question that Steve and I, Chief Coring and I hear all the time is why the fire department? And this is really important for everyone that's listening today. Why the fire department? Three main things, right? It's the trusted brand of the fire department. They are the fabric of our community. They are the most trusted brand next to clergy. And so they're a universally trusted, organization under the umbrella of public health. Their training as firefighters or EMTs, some are paramedics, some are nurses, some are, beyond. But the training that they have as emergency responders, and they have those skills to operate in those high stressful situations. And then of course the trucks, the fire department has the tools, the structure, and yes, the trucks to respond safely and adequately. And that is where I think we can look at this, why the fire department question, in a broader lens with this program, because while they're coming in and they're responding to these calls for 911, for lift assist calls and falls, many times the resident, because of that trust, because of that training, because they are the fabric of the community and they have the necessary equipment, they're able to ask a simple question. Are you open and willing to accept help? And they will say yes, because they know if the fire department is telling them, that they're going to connect them to something, to some type of help or community resource, they know that that indeed is going to happen. Next slide, please. And then again, so why Care Resource Connection? You know, we have a different perspective. I am the wife of a firefighter. So it's very, I would have to say with the fire community itself, it's the families themselves also work and sacrifice almost as much as the firefighters as well, because we know at times when they leave, there is a possibility they may not come back, and we do have to take care of each other and our families, and a lot of times we band together with our kids and our neighborhoods. So it's that perspective that I really wanted to have Care Resource Connection teach communities how we work within this organization. And so we take an agnostic approach. We're not tied to any health system or an insurance provider. And I know that sounds incredibly different, but it was my sole intention working as a care coordinator with North Memorial in Fairview for over 20 years before I opened the nonprofit, was I could not access the help that I needed for my patients if it was outside of my health system. And that made it very challenging. And I couldn't get to my patients because they were outside of my clinic walls. And where, yes, I helped with the community paramedic program, we were able to expand that access. It still was a barrier for me. And so when I started this program and opened the nonprofit, the first person that I called was Chief Coring, because he and other fire chiefs in the West Metro were working on some similar type roles with Methodist Hospital and the Good to Be Home program, where they had the firefighters, connecting after people were sent home. So that's kind of where this all kind of came together. So that expanded access served by the fire department, where we're able to create those community health alliances. We're expanding this across the state. We're in North Dakota, soon to be Wisconsin. And so it's the community knowledge of the fire departments and the community leaders and the stakeholders and those partnerships is what helps us build that capacity. Next slide, please. And so I'm just going to open it up a little bit, for discussion. A lot of the times we have, how we're identifying the proper use of 911. How do you take approach to your community stakeholders on this subject? And feel free to put your questions and comments, and Merritt we can just take these in real time. Is the business model or staffing model, a challenge? We work with many sites, the senior living sites. So we deal with the nursing homes as well as the assisted livings, independent livings. And then we also deal and work with some of the city-owned housing communities. Anywhere where there are waivered services, we can also come in and provide some assistance. And we don't come in and replace what the county social workers are doing. We come on in, we gather the information, and we, again, gather what we know and we send it to the care team. And then if we find out that there is a care coordinator or case manager or county social worker connected to that patient, you are the first ones that we reach out to. The patient gives us your information, gives us consent. And so then we're able to let you know what's going on. On Mondays in St. Louis Park, all of our sites get a 911 call report. And the goal is for them to look at the callers on that 911 report and to communicate to me by Wednesday, where have they been able to connect with that patient and decided if they need additional help, care plans need to be changed, whatever the case may be, families called in. I'm always happy to help out with care conferences. And then hopefully by Friday, there's a plan. So that person's name isn't on the 911 call list for the next week. And that's how we hold our community stakeholders accountable, because it does take all of us. In the beginning, like I tell everybody, When we come into a city, we sit down with the fire department. First, we work with the fire department, determine where the needs and challenges are, and then we go out into the community and we invite stakeholders in. And that's how we continue to build this program. And the building of this program takes a year, because we're going back and forth every quarter, having these meetings and going back to the seniors' living facilities and helping them. We're here not as a punitive space, but we're here to partner with them. Sometimes we bring in the ombudsman to come in and help out with some things that we have for families. And sometimes we're just in there to kind of ask a simple question of, do you need us to help you with your staff on how to call 911? I know it sounds kind of silly, but back in the day, we were telling everyone, call 911, call 911. Now we have to really be cognizant of the fact of, how are you calling 911? If you're in a nursing home where everybody is trained at bedside care during the day, think about it. If the patient needs to be transported to the hospital, is it necessarily the best route to call 911 and have the police, fire, and ambulance respond? In Hennepin County, they have Title IX, so that's what happens. So we teach the staff to basically say, I just need to have a transport to the hospital, and then fire department can, stand ready in a community risk reduction model in case somebody else needs their help for the next 911 call.
And Amy, to your request, folks, if you have experience in response to the questions you can see on the screen that Amy has posed, please feel free to jump in the chat. Very interesting questions, Amy. Appreciate that, particularly just questions about proper use of 911 and strategies for communicating that more broadly. If anybody's heard a message in that regard that's really resonated with them or stuck with them, feel free to share that, and I'll keep an eye on that in the chat.
Wonderful, thank you. All right, so we can go to the next slide. So big picture, right? We talked about the Community Health Alliance. It is with the patient in the middle, the fire department, all of this community health team in the middle of this circle. And in order for this to work, there are things that you have to have connected to your program. So at the very top, where it says HUP, that's our high utilization patients, those ones that are calling 911 repeatedly. So first we have to identify, who these folks are. And then, as with anything, we want to make sure that we have a partner that is able to help us with connections to mental health, understanding the post-discharge needs of our hospitals and our nursing homes, and our TCUs that are making sure folks are having a safe discharge plan. Staffing is always, one of those things, whereas the fire department in general, they're not built, and they weren't built to have a care coordinator, because this is a new thing. So staff is definitely an issue where we have to look at how are we going to have funding to have this staff. And that's where it pays to have the fire department and the nonprofit connect, because I'm able to write grants for these programs, and then we're able to come in and help out with additional staff, additional things we can do. And then we can also go to the health systems and ask for community grants. And then we need to have somebody who's able to go out and do the visits. We call them safe home visits. And then in this model here, we utilize the platform Unite Us, and that's where we are able to put all of our referrals in. The healthcare system can do the same, and then we're able to send the referrals back, and they communicate back to us in a HIPAA protected way. All of that is done with the patient's consent. Home care and hospice, we work with home care and hospice teams, and think about, when as social workers and county workers, when the home care episode ends, that doesn't necessarily mean that the patient is feeling safe and secure in their home. Home may look different. And that's something that, we need to be cognizant of. And so the nice part about it in this program, we're able to work with the home care agencies and those that are graduating from hospice and say, you're getting ready to discharge these patients, and then we can get out there within 24 to 48 hours and do a check-in. And sometimes it's just filling in the gap until they can get somebody else in. Sometimes there's other situations where they might be waiting for a county waiver for the PCA, whatever the case may be, right? But at least we want to make sure that they're connected, their care team is constantly up to date with what's going on. And then we have the other issue too, and this one with the purple one where it says PHCH, the biggest thing here is going to be, this cannot happen. This whole process cannot happen with the synergy of public health and community health. So if there's one thing you get out of this webinar today, it's just really understanding that there's a difference between community health and public health. And together, we're able to do great things. That's what it's all about. It's all about utilizing the resources we have within and expanding upon our current relationships. So if we have public health working alongside of us with our community health model, it allows us to have additional access, additional connections for the resident or that person that's needing the help. And many times a social worker has a huge caseload. They're not able to stop what they're doing and get on out to do a home visit. That assessment may not be due yet, right? So we're able to send over our safe home visit information, our information that the patient is saying, please share, we need this. And it allows us to work together in that space. And all of this, is very, very, it's important for us as a whole nonprofit, the City of St. Louis Park, to really have a DEI and, the B is not in there, but a real sense of belonging, of equity and inclusion. And just having, because we're dealing with the whole diverse needs of many, many different types of folks. But at the end of the day, we really want to instill the fact this is the community, right? And sometimes we're working within communities within our communities, and we know that their access may be a little different. And so for the nonprofit, we come in and we don't say that we are here because we know what it is you need. We come into the community and we ask for permission. Could we get invited? Would you be open to helping us understand the needs of your community and help us put some information together? And I promise you, we'll come back with what you are saying that you need. And we'll come back and we'll have a different conversation about how we can do this, because that sense of belonging is huge. And a lot of folks in a lot of different programs that are out there, they're wanting to do this type of work, but in order to really, really get engaged within these communities, we have to really have them at the table, part of the conversations, being part of the decision-making process, and helping us lead and guide the efforts that we're doing in this whole Community Health Alliance where they live. And full circle, that really makes up that whole Community Health Alliance.
Amy, before we leave the slide, I just wanted to float two questions to you. The first one is related to information we were discussing earlier on, but I wanted to get it to you before we get too far afield. And this might be something about connecting later on to share any data or information that you have. Question about, do you have data to support the reported decrease in repeat calls? And then if this person wanted to understand more about what that data might demonstrate, could they be in touch with you to learn more about that?
Absolutely. Yeah. I always love to share data.
Yeah.
That's really the proof in the pudding to what we're doing. And yeah, please, we have that able to share, and feel free to reach out to me after and we can connect, one-on-one and do that as well.
Thanks, Amy. Much appreciated. And then an interesting question here as you're talking about building that community health alliance and gathering partners together. A question about resistance. Where do you experience resistance at site leadership levels?
It's a great question. I love this question.
Yeah.
Those of you that know me personally, my nickname is a bulldog. I don't take no for an answer. Um, and so I think the biggest part of resistance that we get is people just don't know what they don't know. So they're concerned of, again, remember at the beginning, why is the fire department here? And why are you talking to me about how we're dealing with our residents? Two huge questions I get every single time I go into a senior living facility, a clinic, hospital. And really, as we talked about at the very beginning, it's breaking down that thought process. And I just go back again. Well, this is why the fire department, and really think about it. Who else knows and has the pulse of the community? The fire department have access to the 911 calls. They know more than the providers, than the entire care team, because they're the ones that are connecting on in that 911 environment with that patient, that resident. And so that's the secret sauce, right? And so the fire department has that, and care resource connection, because we're agnostic, we welcome everyone. We don't pigeonhole ourselves. We don't limit ourselves. If we're working with one organization, we're not asking them to change the way they do business. We just want to learn how they're doing what they're doing and how we can support that. As fire departments with the community risk reduction, that model is really, it's set within the communities, and Chief Coring has a huge job with this fire department because he has to look at his whole community and think about how how are we able to keep everyone here safe? How are we able to respond to multi different things, that are happening at the same time? I was on the call with Duluth Fire the other day, and they actually couldn't respond for a very short period of time because they had two people that were taken out to sea on Lake Superior. They had a house fire, and they had another car accident, and then they had another call, and there was another call for help, and they had to tell their dispatch, I'm sorry, we can't respond. And it's those types of instances that every fire chief wants to avoid. And at the end of the day, whether you're living in the city of St. Louis Park, you're doing business in the city of St. Louis Park, or you're part of, the fire department and this whole public service entity, there's a responsibility, right? Everyone has a responsibility to be that good neighbor, to communicate and connect with each other in a way that overall impacts that patient's experience, whether it's their entire quality of life, living on their own, living, safely aging in place with different supports as long as possible, or whether they are, really having to find some different support because we find out through the 911 call that they don't have anybody and they're afraid. And, when it comes into working with communities within communities, that's my absolute favorite piece, because we were working with the Minnesota Department of Health in Anoka County here on a regional health equity grant, and just the amount of learning and just being open and just being honest and real, right? I don't know everything, and I don't expect any of you on this webinar to know everything about everything. And so being vulnerable, being able to have open conversations with community leaders and asking for an invitation, there's nothing more humbling than that. All we're trying to do is connect the community resources to our residents. And if there's a special way to do that, or if there is a special access point, or just what neither of us know, and this is the first time we're having the conversation, that's where it starts. So just keeping it really simple, just having that conversation is where you can really reduce that resistance.
Thank you so much, Amy. Appreciated. The Q&A is also getting lively here, so I'll just share a couple more questions, but I don't want us to. We will try to reserve some time at the end for questions as well. Um, question about where this program is being offered. Any places beyond St. Louis Park?
Yes, actually, we're growing. We are in a growing phase, so much so that I can announce today for all of you that the AmeriCorps Public Health Corps have partnered with us as the first nonprofit to provide public health corps to service members to volunteer with us so we can teach this. And as they're going to get their public health degrees with the U of M, they're going to learn this community model. So yes, we are in St. Louis Park. We're in Hopkins. We are in Fridley. Let's see, we are going to Plymouth. We're going to Minnetonka. We're in West Fargo, North Dakota, Moorhead. And then there are 24 rural counties that are asking for this. And so, yeah, we have a list of people that are saying, hey, we want this, right? And now we have to sit down and say, okay, how are we going to get everybody onboarded, right? Because it starts with different things, and city councils are talking to each other, and we get mayors calling the other mayors, and so it's one of those things where I think in the beginning people thought, let's watch and see what they're doing, and now they're seeing the value and they're seeing the feedback from the patients and the providers and the health systems and all these different things at the end of the day equates to saving tax-paying dollars, right? Who doesn't love that? Um, and so now they want this in the communities. So if you have a community that's looking and you want to learn more, please feel free to reach out. I'm happy to talk to you.
Thank you very much. Wonderful, Amy. Now a question about protected health information. One of our colleagues in the county department is asking a little bit more about how you work with health information, case information, releases, what your approach is there.
Oh, great question. Thank you so much for asking that, because I know that's way the biggest thing that comes second to why the fire department. We have within our program, it's built in patient consent that's HIPAA compliant. If we find out during our discovery process that the patient has a case manager, county case manager, because we ask them for their care team, because especially if they don't get transported, we talk to them and say, the best thing to do is to at least let your provider know that you fell and you didn't go to the hospital. Are you open and willing to accept help for us to help you make that connection? That's where we start. Honest to Pete. That's the very first thing, a very first place we start. And so as they're telling us who their care team is, and if they say, oh, I have Amy at Anoka County, great. We have a release of information that we can send, because every time we are reaching out to anything for the patient, they are signing a consent, they are giving us their authorization, nothing is shared. Even between all these little circles here in this Community Health Alliance wheel, every step of the way, the patient has provided consent for us to connect to every single one of these dots. So their protected health information is at the utmost high security in our program.
Thank you very much, Amy. Another question about initiation. I know you've said that folks are able to reach out to you offline with questions about getting this it started. One question from a webinar participant about how these programs are initiated in different areas.
Oh, sure. So, Chief Coring, he, as a co-founder, he is amazing and has a platform with other fire chiefs that, are always fascinated by his willingness to really change the way that the city of St. Louis Park have a higher level of quality of life because of his leadership in the fire service and on that department. So selfishly, it's easier for me to say, hey, we got Chief Coring, rah, rah, he's a co-founder. But truly, when people are wanting to get on board with this type of stuff, and it's just connecting, back to our providers. We're at the point now where I don't necessarily have to go out and talk about what it is we're doing. People are coming because other county public health agencies are coming to them, or they've worked with someone in a community that has touched our program in some way, shape, or form, or they may have seen Chief Coring on, in an article or on Channel 9 News or whatever the case may be, right? So everyone just kind of knows that this is where the hub is. Everything's tried, tested in the hub of the city of St. Louis Park. And once Steve and I agree that this is it's ready to scale, that's when we scale it.
Again, thank you so much, Amy. I know because I have had the value of seeing your slides ahead of time. I know you have great additional content I'd like to get to. There are excellent questions remaining here that we can explore at the end. I want to just call out regarding reimbursement for services, training for people providing services, and then engagement with facilities regarding outreach if frequent calls are coming from those settings. So those are kind of the three themes that we're exploring. Some of those we might pick up a little bit in our continued discussion. So I'll just mention that we have some more questions ready to go, but let's jump back into the slides for a minute just to make sure that we get this great information to participants.
Yeah, absolutely. So we can go to the next slide. So again, we're just going to go through this circle. The examples of 911 calls, either they're transported or they're not transported. It's those non-transports is where the patient is at the highest risk, because nobody knows but the fire department that these folks need help. Next slide, please. And so those post-hospital discharge visits, right? Or on mental health, sorry. So mental health. So police and fire, are post-COVID, even before, we all have to really acknowledge the fact that there's a huge need for mental health. Hospitals can't keep, dealing with this in their emergency rooms. It's just not, we're at a crisis point, truly, with this mental health crisis. And so the Community Health Alliance as a group, I can speak for the city of St. Louis Park. Let's start there. So Chief Coring and the police chief with the city of St. Louis Park are really focused on how the Community Health Alliance can work within the city of St. Louis Park and have a moving, mobile response to mental health. What does that look like? That's where we have the conversations and we come back together again as a group of the Community Health Alliance, and we say, doesn't necessarily look like we need to come in and transport them to the hospital. Do they need to be placed in handcuffs right away? Or is it a situation where we can say, hey, here's an iPad, and have them connect to somebody virtually, or have somebody alongside? Because at the end of the day, we have these embedded social workers within the police departments, and every police department that I've spoke with in the metro tell me the same thing. Mondays through Fridays, during daytime business hours, great. Johnny on the spot, we have the social workers. It's after 5 p.m. what's happening. And that's where the police departments are calling Care Resource Connection. And we're saying, okay, how can we start having larger conversations about this need, this true need of how we can meet these folks where they are? So that's really where this is our focus, starting next year, and we're already starting to gather our groups along these conversations. But Chief Coring and the police chief of the city of St. Louis Park and the city council as a whole, and the mayor of St. Louis Park really, really value this initiative. So stay tuned, folks, because there'll be more coming here. All right, next slide, please. So post-discharge visits, yes. So as I said before, Chief Coring and other fire departments had partnered with Methodist back in the day for a Good to Be Home program where they had post-discharge firefighter visits. That program has since um, pretty much gone away. And so what we're doing with the hospitals is we're working with the hospital systems and their trauma coordinators. So for example, my office is in Anoka, and so the trauma coordinators for Mercy and Unity had reached out and said, hey, Amy, can we know you're working with fire departments, you're doing these things. Can we send you referrals for patients that are discharging for falls with a clear head scan and knowing that they need to get some help? And along with their community programs and their discharging for home cares and things like that, it's a new way for us to keep that patient from returning back to the hospital. And then those transitional care units, right? Those folks coming home, we're seeing a huge increase in patients coming home from the TCU, and then they're realizing, nope, then they're going back to the TCU again. And that cycle, we want to break that cycle. And so we're having conversations with the discharge planners and the social workers at the transitional care units, because we know the minute that they are transitioned from the hospital to the TCU, the very first meeting the care team is doing, in your interdisciplinary teams, is you're having a conversation about your discharge plan. Are we dealing with physical therapy? Are we dealing with psych? What are we dealing with, and how many hours is it going to take before this person is ready to be discharged? And it's that conversation that as we get closer to them discharging, they communicate back with us and they say, hey, this person does not have, they really want to go home. We have, home care that can come in, but they can't start until ABC time. Could you come in and fill that gap? Knowing that we want to make sure that they are home, they have access to food, access to medications, everything that they need, and have eyes in the home, right? And kind of report back and make sure that, within that first 24 to 48 hours, they're not calling 911 again and wanting to return home. And same thing, for the emergency department. People can go to the emergency room. They can be full of, patients, and many times we've all done it. I've done it at North Memorial, and I do it here too. I will call the social worker at the ED and say, hey, they are not safe to come back home. We're dealing with, we need to figure out a plan, but this is what we have found, the state of the home. And there sits that social worker at the emergency room going, okay, what am I supposed to do with this? This is an emergent situation. And so we become that partner, right? The community partner. We help kind of build in some supports, and we could not do that without the partnership with the fire department. So next slide, please. So again, right, we talked about staff. I'm seeing some questions in here about, wanting to connect with our staff and doing some different things. Happy to help. But when it comes to, key staffing considerations, Steve and I have these conversations all the time, right? Not just any firefighter can do a community health. And actually, in the beginning, we thought, well, we could do the job and we could do it this route, but we found that they're torn. Am I responding to a 911 call, or am I going on a safe home visit? And the person that's going to be in this role needs to be focused on community health, because there's referrals coming in every day. There's 911 calls coming in every day. They need to be able to have, the skill set and to be able to work in this type of an environment. And so what we do in our program is Care Resource Connection and St. Louis Park Fire. We have a program with Normandale Community College, and then Care Resource, we just signed on with St. Catherine's, and we bring in their community healthcare worker interns, and we teach them this program. and we show them how it is working within and with a fire department. And so by doing that, it allows us to increase our staffing. And then because we partner with the Community Health Alliance, the Community Healthcare Worker Alliance, we are able to share that we have access to, sharing out the scholarships to do the community healthcare worker program, and then the apprenticeship programs that are out there for cities to utilize. So it's really been, how can Steve and I have really worked hard on trying to find that creative way to build this staffing model in a entity, right, in a field that has never existed before. But we all know that having that community healthcare worker is so key, because that allows us to be able to be flexible, have, that reimbursement model that we'll talk about later, just all different types of things. And they understand their scope of practice, how to stay in their lane, and they learn those key things during those internships. And that's what we'll be teaching the AmeriCorps Public Health Service members to be doing too. They start in October. So that'll be really exciting for that. Next slide, please. So the visits, what kind of visits do we do? So we call them safe home visits, right? I call them the safe home visits because a couple of different things. When we originally started working on this program, we were working with DHS in a model that had a community EMT, community paramedic, and the community healthcare worker, and they're called safe home visits. And you can bill through that, line of service for persons that are calling 911 repeatedly, repeated falls, repeated calls for ambulance, at risk for nursing home placement, those types of things. That was our, honed in focus when we first started. And, we've grown and learned and, learned our lessons along the way of what all lives in here and who should be doing what in this space. And so the community EMT program is, I'm not sure if it's on hold or kind of where it is with that, but so we really turned our focus to the community healthcare worker. Because we know in the fire service, we already have the EMTs, we have the paramedics, we have, these types of folks that are already, working within the department. But we need to have those folks that are boots on the ground going into the homes and doing the visits and being able to be the eyes and ears of the entire care team and bring that information back. And so that's where we came up with the safe home visits. So they do the initial safe home visit, and then we have our follow-up visits. And again, what makes us unique is because we do a follow-up visit on 30 days, 60, 90, and 120. We stay with that patient throughout their whole continuum of care, follow up with them, doing a promise survey. Each time we do our follow-up visit, we connect it back to the care team, because we don't want to have this roller coaster for these folks. And you hear so many times about people talking about, we're disrupting healthcare and we're doing this and they're aging friendly. I don't see the data. We have the data that proves that this program, if it's followed the right way, and that's why Steve and I are very intentional about where these programs go, because the way we've built it, the integrity of the program must remain the same. The visits need to remain the same. The follow-up needs to remain the same on those 30, 60, 90-day follow-ups, and the promise survey, because by doing that, we can look across the spectrum of the Twin Cities and say, okay, here's where we are here, here's where we are here, and really start having a real, HEDA analysis. And that's what really excites me at the end of the day, is as this grows, our data grows, and we're able to learn just that much more about the true needs of our community members. And so we do have those electronic healthcare record system within the fire departments, Care Resource Connection. We're working on a system that's going to be called CRC Connect, and it's going to be the first electronic medical record system that starts from the 911 call and goes all the way to the 120 days, and it communicates to Epic and the hospital system. So it just there's no interruption there. And Steve and the city of St. Louis Park and Care Resource Connection working together on making sure that that's coming from the Alliance and that's something that folks can utilize. And then scanning of the forms, you know, same thing. Our visit forms will be in there. It comes to the provider and Epic as a PDF. And so it's attached right into the patient's medical record. So it just allows everybody to be on the same page and for us to kind of go back and forth. So when we go back for that 30-day, we know, oh, okay, so Amy was seen, Steve went and saw her, she's got home care, PTOT is getting ready to, you know, end soon. And now we have, you know, Caitlin is the county caseworker and she's working on paperwork to get a PCA and all these different things. So by the time we get to, you know, that follow-up 30-day, we have a really clear picture of all these things that, you know, we're all doing behind the scenes. And now we're putting them together and we're saying, okay, what's working, what's not working? Let's talk about your social determinants of health. And based on the data and the promise survey we're doing at these follow-up visits, what does this look like now? And that's the larger conversation. Next slide, please. And so Unite Us is a platform that we're currently using. They are a social health platform. I was called by a couple of the health systems and Unite Us because they wanted us. I apologize. Again, I'm across from the fire station, so this is just something, it's normal for us to hear the noises. So as far as the referrals in real time with Unite Us, the care coordinators in the hospital systems and the clinics, they have access to this. So when they're talking with their patients and they're seeing, oh, you know, I think this is something that we should have you connect to the Community Health Alliance in St. Louis Park, they'll send a referral to us. And then we can also send a referral, you know, back and forth. So it just allows us to communicate that way, and then it allows us to invoice and bill for those services as well. Next slide, please. And again, like we talked about home care and hospice, right? We know that home care discharges, sometimes that happens, and looking at this, patients are still at risk. And what happens, you know, when the patient needs something? They're going to call 911 again. And then we have to start that whole thing over. And the real critical piece too, which I think is so, the city of St. Louis Park and the St. Louis Park Fire Department are tremendous advocates and leaders in this program when it comes to our hospice residents, because they understand if they respond to a call for a family member that has someone that's on hospice, they will have that conversation with them and understand that if they do get sent to the hospital, their hospice cares, you know, end at that point. So they're really advocating to say, oh, hey, I understand you called 911. Yes, this is very stressful. This is happening. Hey, have you reached out to the hospice nurse? And just that moment of, oh, okay, fire department's here. Yes, let's do this. Let's, you know, take a step. Let's take a beat. And I can't explain to you the amount of pride and ownership that the fire department has doing this type of work. And it's changed the game in such a space where Methodist Hospital and Park Nicollet Home Care and Hospice are doing these discharges with us. And the foundation actually provided our Community Health Alliance with a grant for 3 years to have a care coordinator be at the station. So I'm not having to do that work, you know, day to day. We have Tanya doing that work, and then it allows Steve and I to continue to bring on and train more sites, more cities on how to have this program. So next slide, please.
as we move forward, Amy, I want to draw our attention to the fact that we have reached 1 o'clock. I cannot believe it because
Oh, sure.
a fascinating this is just such fascinating collaborative work, and it's very meaningful. The Q&A and the chat have been really lively with questions, so if you are able, I would love to just finish moving through the slides here, um, just through the rest of the circle, so if folks are available for another couple minutes, we
Yeah,
could hang out. And then there are just a couple I think rapidly answerable questions that we might be able to jump on there right at the end. So we'll
perfect.
just take a couple more minutes for those who can stay on. I want to be respectful of time, so we'll just take a couple more minutes so that folks who are interested and available can see the conclusion of the wheel here. So valuable. Thank you so much,
Exactly.
Amy.
You bet. All right, so next slide, we're on to public health and community health. And that's where I think a lot of folks are going to have the questions, and please feel free to reach out to me. I'm happy to go over it with you. So again, it's synergy, right? Boots on the ground for community health versus the aerial view of public health. Public health has such a huge responsibility and such a huge geographic area to cover. We truly look at being your support. We look at those of us that can come in, gather the information, and hand it off to you. I want you to look at this program as your partner. And when it comes to building that trusted connection in with our senior communities, nursing homes, things of that nature, we've done that. We've been recognized by Concho. And so we've done it with Hennepin County Public Health. And believe it or not, having that kind of come back and forth, having those resources be reintroduced again to the community that we all know are there, has really been a huge, huge piece of support. And as we're dealing with our senior livings, and then that data sharing too, right? That's where it gets a little tricky because, public health can't necessarily, send information back and forth and things like that without that patient consent. And then also, working in the schools and supportive housing and really breaking down those silos is really the key of having public health and community health working together. Especially during COVID, we really saw the need of that. And I think it opened everyone's eyes when we kept hearing it's the community health, it's the community health. And people were calling the fire station saying, we're told to call community health for PPE, and public health going, hey, what's happening? And we all had to come together. And that's really where we were able to kind of delineate what can community do, what can public health do, and how can we come together. Next slide, please. And so again, I'm asking all of you, think about this as we end the webinar here, what type of collaborations are y'all doing? What type of collaborations do you see in your area? And if they're not connecting to a community health space and connecting to what Steve and I and the Community Health Alliance are doing, please reach out to us. We're more than happy to help teach you how to build this type of a program in your area. And then when it comes to, again, to DEI, I really want to add the B for belonging. I think that's just something that we all need to start, recognizing. And when this was done, we didn't add that to our training at the time, but as part of the Anoka County grant, we're teaching all the Anoka County Police and Fire diversity, equity, inclusion, and belonging training. So when it comes to our historically underserved populations, it's more than just coming in and acting as if what they're needing and gathering information, and then leaving and then not coming back. And truly, if it's one message that every leader has asked me to share, it's we want to belong. We want to be part of the conversation. We want to be at the table. We want to be part of the change. And we want to show how we see ourselves making a difference and being included in this community.
Amy,
All
thank
right.
you so much. I'm tremendously grateful for you for again taking extra time Just tremendous gratitude coming in the chat and the Q&A too. I'm not sure if you're having a chance to see that, but folks are appreciating really hearing about this very innovative program. Lots of questions and great questions. I just want to share with attendees who've been able to stick with us for a few extra minutes. You know, Amy has been incredibly generous in offering to connect with folks who have questions. Amy, I do see I see a question here about case manager involvement if a person already has a case manager. And if I can summarize, I heard you say that that person remains involved and a part of
Oh, yes,
the process. Absolutely.
absolutely.
And then I also, with regard to outreach to facilities, you know, if a lot of those 911 calls are being initiated there, and I did hear you say you work with the Ombudsman for long-term care. I know
We
that
do.
that's another great source of engagement to help engage facilities, and expect that's just a part of the outreach that you do in that regard.
Yep, absolutely. Yeah, and it's just one of those things, we have the meetings, and it's nice because we sometimes will come into their coffee meetings and have these different types of conversations. When I work with the sites, I ask for a few different things. We ask for their fall policy, their elopement policy, their CPR policy, and funny, their 911 call policy, which we're starting to, create. So those are the things that we really focus on and support them with. And obviously, we're we work with their 911 calls and the families, because sometimes, people will just sign themselves out and there's not much you can do about it. And so we all have to work as a team, right? Because we know we're all going to come together anyway. So it's really about being proactive. And like I said, bringing that community together is really what it's all about. And every community is different. And so it's really important that whoever wants to have this program, yes, we've created this outline, but when I come into your community, I'm really specifically tailoring this to what is needed in your community.
Well, Amy, thank you so much again. Another a wonderful presentation, very informative. Much gratitude coming from the webinar audience, and also thanks to our webinar audience, folks. Really, lots of folks sticking with us to the few minutes after 1 o'clock. So just we have much gratitude for people who are sharing their time with us in this way. Amy, tremendous thanks to you and to Chief Caring too as well for the information that he very generously shared in the Q&A box via typing throughout the presentation. Thank you so much. And again, we'll look forward to hearing more about these kinds of programs. And according to, I'm expecting some survey results, you may be hearing from us to come back and talk more about the work that you're doing.
Sounds good. Happy to help anytime. Thank you so much, everybody. I appreciate your time today.
Thank you, everyone. We'll see you next time.
Take care.
Thank you.